Welcome to the show. I'm your host, Dr. Joseph Coppus, and I'm joined today with my guest, Dr. John McClaren. Thank you for joining me today.
It's a pleasure.
Yeah. So, taking time out of your Saturday to spend with me, it's always great.
Kind of awesome.
Yeah. So Dr. McClaren, you wanted to go over a few cases with us today that really demonstrate kind of the breadth and the depth of what functional neurology can do for various patients. Is that right?
I am going to do my best not to embarrass myself and do that, absolutely.
I'm sure it's going to be phenomenal, so I'm excited for this. So before we dive deep into these case reviews, can you just give us a little rundown of your personal story and what got you into this and interested in this field?
Absolutely. I went to chiropractic school at Parker College in 1998. I had always thought healthcare was where I'd be. I had those orthopedics or anesthesiology or, something where I wanted to help people feel better. My cousin said, why don't you go into chiropractic? That's kind of up your alley. And I don't know how he knew that was up my alley or not. He's a mortician, so figure that one out.
Yeah.
But he said, why don't you check chiropractic out? And so I did, and it was kind of one of those things where it resonated with me pretty well. I had a shoulder injury. I was a collegiate power lifter, and the orthopedic stuff just didn't work for me. And found this chiropractor that at the time practiced in Blair, Nebraska. I live in Omaha now. I was in school in Lincoln back then at the university, and this guy did some ART and some chiropractic applications with me, and I got my function back, and I was hooked. And I said, okay, that's what I'm going to do with my life. And so enrolled in Parker in 1998, and I had a friend who was in the neurology program with Professor Carrick at the time. And you know how that goes. It's you probably get somebody who attracts you to the thing too. That's just like, man, you got to come see this guy talk. It's amazing, And of course, as is the case still to this day, 20 years later, Professor Carrick talks, and it's, here and now I'm, here, and then I'm at the ground, and I'm like, I don't know anything of what he's saying, but it sounds really good, and he shows these cases, and you just go, wow, yeah, I want to do that. And my dad had a traumatic brain injury. When I was in high school, he got thrown off a train, actually. He was in a multi-train collision. He was a locomotive engineer. And he went through this whole deal with Craig Hospital in Denver, who's really, really good. And he had an awesome neuropsychologist, the medications and those kind of things. And so, this was well before I went to chiropractic school. But I went and I took some seminars, and I did some neurology club things at Parker. We kind of had a club back then going. And, so you come home and it's like, ooh, I picked up this trick, what do you think? I'll start looking at some of these things with my dad. So my dad was my first neurology patient. And he's one of these guys, he's like a lot of mild traumatic brain injury patients where, they hear this over and over. I look fine, but I'm not fine, and I every support group, to jump ahead that I've ever spoken at, that's kind of one of the questions I lead in with people. I'm like, how many of you guys have heard, well, you look fine, and every hand goes up, Yeah. And you can see the frustration that goes with that. So, my dad is told, hey, you look fine, you're fine, you're gonna, you've got me. So I go home and I try this stuff with my dad, and, some of it works and some of it doesn't, and, some of it, why, and some of it you don't. And I just kept getting more and more neurology. And finally they brought the program onto Parker, onto campus there as I got toward the end, and I could actually receive my credits for doing the program. And I hit the ground running. I graduated in 2001. I took my diplomate in 2005, which is, you know how that test goes. It's like it's 37 degrees Fahrenheit in the room, and you're still sweating because you got these examiners looking at you. And I passed, and that was awesome. And then I got really, really hooked with the mild traumatic brain injury and concussion world. even at that time, because of my dad, and that's kind of the way I think a lot of us go with our stories, is we've either got a personal horse in the race, or we've got somebody we've advocated for with whatever it is that our passion is. You get people with dystonia, have either had it or they have that in their family, or, Parkinsonian disorders, whatever. So that kind of drives our passion for this. And then you get somebody like Professor Carrick and everybody that I have taken, most of my functional neurology training through the Carrick Institute. So, I mean, all the faculty just, they really can extract that passion out of me really well. And it's been one of those things. I took the mild traumatic brain injury fellowship program through the Carrick Institute, and again, you take that board exam, and it was like, that's the neurology board on steroids.
Yeah.
And I left thinking, I haven't learned anything. You take 3 years of classes and you go to rounds, and I pass that too. That email comes in, and it's just like, woo, have a shot and party. And it was like late at night, and then I'm like, okay, I can finally go to bed, but I didn't sleep.
Yeah, how can you?
I've been a functional neurology practitioner, clinical neuroscience, since I opened my practice, and I've taken continuing ed and different programs through the Carrick Institute since then, and here I am, like almost 20 years later, just trying not to screw up too bad.
Excellent. And you kind of mentioned that in the beginning you felt like you were down here, and then eventually you get a little better and better, and it's just a lifelong of learning and trying to perfect your craft and your skill, right?
It's a lifelong process, absolutely.
Yeah, absolutely. So, and that was such a good story that you were able to utilize what you were learning with the Carrick Institute and the functional neurology training, and actually apply that to somebody you love. So your first, patient was somebody you love and who's someone you really wanted to help. And then after that, you're able to perfect it and then, really help so many people in the public. So let's get into let's get into some of those first cases that you wanted to talk about that you've seen.
Absolutely. You contacted me about this podcast, and I'm thinking, me of all these people, and I'm talking to the guy that I practice with, and I'm like, what the heck am I going to talk about? We've got giants in this field, just these world-renowned experts, Dr. Traster, Dr. Kaiser, obviously, Professor Carrick, again, that goes without saying. And if I didn't name you, I really apologize. You guys are all, again, here I am, and you guys are way here, and all that. And so I'm like, gosh, what am I gonna talk about? And he said, you have this guy that comes in who I'll get into what I do with him, that kind of made me think this was where I was going to go. He's like, why don't you talk about that guy? And I was like, that's actually a really, really cool case. And, of course, with all these, I get disclosures and things like that. And I'm not going to name names or anything, but just the cases are really, really cool. This guy that I'm going to start with, he was a police officer. I call him a kid. I don't know why, because he's like only 2 years younger than me. But he was a police officer on a high-speed chase. It was an Amber Alert that he was after somebody in where he lived, and so he's going 120 plus miles an hour after the bad guys. Outstanding guy. Was a Marine before that, and had done athletic stuff. Just one of those guys who has served other people his whole life, and he goes through this thing. He's on this Amber Alert chase. Somebody doesn't realize, hey, there's a cop on an Amber Alert here, so they pull out into traffic in front of him, and rather than hit this car, because this is the kind of guy that he is, he swerves off and drives his car full speed into a guardrail. So you can imagine, obviously, he had some pretty significant injuries from that. And this, you get into these more moderate to severe traumatic brain injuries with these guys. And, again, there are people in our profession that see a lot more of these types of cases than I do. I mean, you see the work they're doing at plasticity and the guys in Chicago, you guys, you just have this way with these patients that's really inspiring to me. So it's like, I'm one guy here on my own. What can I do with this guy? And he comes in to see me, and he's in a long-term care facility. So he's living there. He had a hypoxic brain injury, some significant bleeding. He's really, really hemiplegic on the left side of his body. And the poor guy, he comes in with a completely extensor-based posture when they first got a hold of him. So, he's retrocollically flexed and again, really drawn up. So they, the medical people, when they get those, they'll Botox these guys, right?
Mm-hmm.
You see a ton of that where they got to get the contractures loose, because then the thought process is, we can stretch him, we can work him. They do what they do, and they're magic. I mean, they did some fabulous stuff with this guy by the time he got to my clinic. But he'd been going to a general chiropractor just because he's got a lot of neck pain. So long story short, they Botox him, they Botox him, they Botox him, they Botox him. So now his head is hanging down, so you can imagine his neck's pretty sore.
Mm-hmm.
But the thing with his presentation that was kind of unique is he's got these nystagmus patterns where he still neurologically perceives his head as retroflexed, even though his head is flexed forward.
Right.
You go, well, shoot, what am I going to do with this thing, And, I kind of wanted to get him into some gait stabilization strategies and things like that. One of the things that we'll do, when you work with spasticity, a lot of people do contracture stretches and things like that. And we did some different things, some gait protocols and some complex movements and things like that. And he responds really well to that. But I'm thinking, I got to see, at the very least, if I can do more than just like activator adjustments on his neck to relieve this. And our thought process generally in neurology is if we can get the head movements to match the eye movements, to kind of try and match these other sensory maps and things like that as best we can. Granted, his aren't going to match up like, say, yours or mine, perhaps because of his significant injuries.
Right. But
if we can do some things to get that to happen, that'll be great. But here, this guy's eyes, and he's funny. He's got a great sense of humor. But I couldn't understand his speech patterns really well because he doesn't have super good motor speech at the time either. And so I kind of think, well, okay, let's see if we can get him to do some gait stability once I get him kind of calmed down enough to be able to do that. So we lay him down supine because it works really well. Do some passive head movements. And he won't attend to my nose or he won't attend to, I've got these grids on the ceiling with dots and things like that. Mm-hmm. And so one of the unique things with this case was, he can attend if he's really, really into a target. But he's not into this target, which I don't know why, as handsome as my nose is. And he doesn't want to look at dots on the ceiling or, crumpled pieces of paper or things like that, which are things we use with a lot of applications. And I remember, Professor Carrick telling this story about a Swedish hockey player. I wasn't at the rounds that this guy was at, but, they were trying to do similar things with him, saccades and gait stabilization strategies. And this guy, he's a hockey player and he's kind of a young guy and he wouldn't look at any of these targets. So they started putting boobs up for this guy.
Okay.
And I thought, and so that's kind of one of the stories, if you've been with Professor Carrick through some of these TBI rounds or TBI classes, it comes up. Dr. Whitaker mentioned it at his Focus Builder seminar that I was at a couple weeks ago. I think he was rounding with that guy maybe. And those guys did a great job at that seminar. And that reminds me again, okay, where this story kind of came from. So, I kind of asked him, I'm like, are you a boob guy or a butt guy? And he laughs and he gets this kind of smile on his face and he's a boob guy. So I guess it's therapeutic for me as much as him. When he comes in, we find pictures of targets that he'll into. We call those salient targets.
Right.
And man, the guy's eyes just lock right on these darn boobs. And we start to do some gait stabilization strategies. And the fun thing about that is the spasticity relaxes as we kind of work through that a little bit. The head kind of starts to loosen up a little bit. And I didn't do any manual strategies with him at that time, but I've been working with this guy for a little while now. It's always interesting when you see these guys come in. They're in a wheelchair. They're coming from a care facility with a van, and some of us kind of go, yeah, this is going to be a really interesting case, and some of us kind of go, man, do I have the chutzpah to deal with this? Right. And it's it's been really good for him. I've been working with him, not quite a year now, but. And I don't know if it's just that I've been around him enough that I understand him better, but his speech seems to have really improved. He tells, more than 2-line jokes. He sentences, things like that. You still have to kind of pay attention to understand him. But long story short, I ended up, and I do a practice that combines some functional neurology with some more general chiropractic work. I do some functional neurology applications with everybody, but still see some more straightforward types cases. A girl that comes to see me for chiropractic work is a friend of his, goes to visit him every couple weeks, and every time it's like, man, you are really doing some things with this guy.
Yeah.
I can understand him. He picks his head up and he looks at me, and she kind of made fun of him about, the dad said, hey, you guys are looking at boobs all day, right? And he says salient targets to her, and I said, oh, that's exactly what we call that, salient targets. Mm-hmm. So he gets this grin on his face every time I say, hey, you ready to look at some salient targets? And we've built him up. We do some different strategies than gait stabilization mm-hmm. now. And his father is an older guy and does a lot of help with like transferring him and things like that. And the facility that brings him in, the workers, they transfer him, and he can walk aided, but they just all, they just salivate when he comes to see me, because the transferring is so much easier, which I just love, because I'm like, hey, we're helping this guy out. We're helping the caregivers out, because they are able to work with him more, and he moves in and out of the shower by himself now, and he can speak more. He can kind of start to hold that head up a little bit better. Granted, because of the Botox and things like that, I know we're never going to bring 100% of that back. Yeah. But just we see a lot of improvements in those types of cases. And again, I'm sure some of those guys that deal with more of those would probably go, oh man, that's easy. But to me, it's really, really thrilling, and the family really likes it. He likes it, I think, and yeah, that's been a really fun case to work with.
Excellent. Well, a lot of people, we talk a lot about mild traumatic brain injury on this show, but we haven't touched on moderate to severe, and this is one of those moderate to severe cases. How does the expectation for outcomes differ, maybe with an MTBI, mild traumatic brain injury, versus more the moderate severe? Like you kind of touched on it a little bit, but
Sure. The thing Professor Carrick has really drilled into all of us a lot, I think, with dealing with patients. He'll bring somebody in, and if there's one thing that I can do for you, what's it going to be? He really triangulates that well, because a lot of times we'll look at diagnostics and get really excited about changing, saccadic latencies or, CAPS scores or something like that. Oh, your balance looks better. And they go, well, I still have these daily headaches, or I still have this or that. And of course, the more significant the brain injury and the more significant the sequelae from the brain injury, the disability or things like that, the harder it is. You go 100%. In a lot of brain injuries isn't really super attainable, but that's the thing. We say, well, what do you want to do? And they came in really, and I think I exceeded their expectations in a lot of ways. Of they just wanted his neck pain to be a little bit better, because the head's drooping and the darn neck hurts. Yeah. And here I come in, I do all these things, and so because I asked what they wanted, and then I did some things that were really beneficial in other ways, but that also aided that strategy that they wanted done. They're exceeding the expectations of what they thought they would get with him, mm-hmm. Which is nice. You don't always do that. You don't always get that lucky by any means. But those major traumatic brain injuries, you just kind of go, can we do things to make the caregiver's life a lot easier? Is kind of my thought process, because that person, that they're gonna know, they know they're not what they were before, but you try and give them something back, try and give them some autonomy back. They say the guy can transfer into the shower himself now. He's really happy with that. That in a nutshell, you just try and give them something back that they've lost. You may not give them all of that stuff back. And with those major ones, where there is some really non-soft, these hard neurological lesions, that's kind of what we look at. They're going to have some significant permanent impairments, but if we can minimize those and we can give them, the guy wants to watch the Husker game. Well, he can't look up to see the he can't look up to see the darn game. This year he can watch the game, and he likes that. So.
Yeah.
So that's a big piece, depending on how we do, that's a big piece. Sometimes
Yeah.
you go, gosh, I wish I could watch this game.
Well, you guys are playing Ohio State today, and that's who I root for. So sorry about that.
Hey, man, I'm just hoping we cover.
Yeah. Hopefully we don't blow you out too much now. But so we talk.
So
go ahead. Go ahead.
Oh no, I'd say in a nutshell, you just look to give them something back that they've lost, some kind of autonomy, even if it is just being able to watch a darn football game or being able to shower unassisted. It was kind of great with this guy. He didn't realize he could do it, and he did it. And he kind of hurt his shoulder because he got over using his pole into the shower so much easier than he thought he could. So we did some myofascial and chiropractic applications for his shoulder, and that he was happy. That was gone like the next visit, so he was really happy about that. But
excellent.
Yeah, in a nutshell, I think that's the thing. Is it's going to be different, and it's going to be harder to get a lot of permanent change. But the thing is, he's got a good team on his side, and they really kind of work with some of the applications that we do, and it just makes their job easier. So he gets these really, really faster progressions than he did before we started to do this kind of work. And that's a great thing. I see him every so often, but these people that work with him every day just go, man, he's, in the last year, he's really made some significant strides. And I go, well, maybe that's me, and maybe that's just where he's at in his injuries. But, I think we can at least take a small amount of credit for not screwing that one up too bad.
Right. Well, he's really lucky that he found you, and that you're able to provide him with some improvement in functionality. And you had mentioned that he was a police officer, correct? And I feel like a lot of times we talk about sports injuries and concussion, football, soccer, hockey, whatever. But I feel like we don't always touch on some of these more common workplace environments where people are prone to head injuries, especially your law enforcement, your firefighters, your militaries. What are some typical, I guess, workplace injuries that you see, or I guess concussion?
In the concussion and TBI world, I've got a few that were police officers that I've seen. One that I've worked with, I remember I mentioned Dr. Whitaker and Dr. Callip kind of came down to hang out for College World Series last year, and one of the people we ran into was staffing security there was an off-duty police officer who I've worked with on TBI. So we see her, and it's kind of like hugs and this and that. But she had had an injury on the job, and she's still dealing with sequelae of that. But again, she's done really well with some of the things that we've been able to give her. And so police officers are a biggie. A lot of people that drive for a living, we'll tend to see, because the auto collisions tend to cause a lot of these guys. And I will say, I get a decent chunk of athletes in high school. I don't get much of the collegiate stuff because I'm not networked with the University of Nebraska yet in that aspect. Creighton, there's some soccer and things like that here in town. I'll get a little bit of that, but yeah, a lot of it is people, that I see in automobile collisions. Most of my traumatic brain injury work, I'd say, is along those lines. Truck drivers over the road, or people who have to drive just, commuting as part of their day.
Yeah, those can be pretty dangerous, and yeah, absolutely.
Big city, because we're a mildly big city with some congested traffic. You get those kind of things. Some stuff. Maybe somebody's a shelf stalker. We've had a few of those where something comes on their head, so they get some compressive injuries on the head and on the neck. So there's a lot of that kind of stuff out there.
Absolutely. And now I want to make sure that we get to. I know you have more cases lined up for us. So I want to make sure we get to the next one. So.
Oh, sure. So, and along those lines, the case that the next case I'll talk about, the gal is a personal trainer, but at the time she wasn't a personal trainer. She had worked with some disadvantaged youth in like a social work capacity, takes a takes a friggin' right hook from one of these kids that she worked with, and ends up, getting a TBI due to that. And she kind of left that field because of it, and had suffered for years. She's got this constant dizziness, this neck pain. And again, this is one of those gals you look at, she's fit, man. So people look at her, and she's not only fit, she has got willpower, just this amazing willpower and ability to put a smile on her face no matter what. So you would never know. Here she is, really, really suffering, but then you get her in, and I'm not sure how she exactly found me. I think she saw the other guy in my office, and he does dry needling and Graston and things like that. So he was doing some muscular applications with her, and these headaches and all these things she had didn't go away. And it was kind of like, oh, hey, this guy does that stuff. I better talk to him. And so she books an appointment, and we kind of start to go through her case, and she's got just this terrible inability to not even hold a target. You see the eye movements and things like that. And that's something that we see commonly with concussion and traumatic brain injuries. People just have a tendency, not to see super duper well, and they compensate for it as best they can. They'll change the way they move their bodies. They'll figure out, they don't even know they're doing it sometimes, but they kind of figure out, well, if I just kind of look this way instead of straight at you, things look better. I don't get sick to my stomach, things like that. And she'd kind of done that. She'd really compensated physically in the way that she moved. And so she's got these orthopedic things, the neck pain, the headaches, but, this random like hip and Achilles and stuff like that. And so I'm like, okay, well, there's something here that we might be able to do. So we ran some diagnostics on her, and found, yeah, she can't hold a saccadic target to her right side at all. You run the saccodometer on her, and it just, saccodometry is a test that we do where we put headgear on somebody, and then we measure the eye movements, the fast eye movements, and we get 100 of those done, so it's statistically significant, because that's the thing that we want to do is be able to see statistically where the problem is, and statistically can we affect the problem in a positive way. So these graphs should, depending on the graph, it should look kind of like a hockey stick on like position graphs and latency graphs. And then you get into phase profiles and velocity graphs. And the velocity graph should kind of look like, a V, skewed toward the left a little bit. And the phase plot should just look like a single camel hump. Mm-hmm. And you have rightward eye movements are green, and leftward eye movements are red. And they should all just be kind of humped on top of each other. And this gal comes in, and it just looks like spaghetti on the map. It was like this meme I saw where it's like, my heartbeat during the Huskers games, it's just spaghetti everywhere, because, the Huskers are really in these nail biters all year. But her, her saccadic eye movements are just all over the place. So you go, there's a lot of things going on here. You don't hold targets super duper well. She had issues with accommodation strategies, which was kind of her compensation. And again, we'll tend to see a lot of that where people will use different reflexes in their brainstem and midbrain to see, because other things don't work super well. So she goes out and she moves with these clients all day, and she's out, but she can't balance her head and her eye movements at all. So by the end of every day, she's just, I'm just fried, man. I'm 30, I'm 34 years old. I got to take a nap at lunch, and I got to go to bed early. And, she's single, and she's got the social life, and she doesn't have anything to give any of the rest of her life. And she tries hard, and, she'll power through, and a lot of people try to power through, but, one of the things we want to do, and with her, it was, let's get rid of the darn headaches and see if I can get some energy back.
Yeah.
And you get to kind of look at other things with her too, besides the saccodometry. We threw her on some foam, and you move their head in various positions, because we want to see, what happens with your balance in these same contexts as how you move your head in your normal life. Mm-hmm. And again, like I said, you look at this gal, she's got these quadriceps that you just go, man, I wish I had quadriceps like that, and, you put her on foam, you close her eyes, and boom, off the back she goes. And she thought she was going to kick this thing's butt, Yeah. I'm not going to fall off that. And she falls off the darn thing.
Yeah. So,
I see that. I would imagine, and it's like, this is an athletic looking, female who can run circles around me and you know, this kind of stuff.
Yeah.
And you know, so we did some things with her to kind of get that reflex that she was using to strategize the upregulation of the TVOR. We call that an accommodation spasm. We break that, you know, and she, you know, she kind of almost cries as soon as we do that because the headache's gone, you know, and then okay, well, let's see if we can work on some of these other things. So we did some different applications with her, you know, again, some complex movements, some visual strategies, you know, some eye-head movement strategies. Dr. Carrick calls it eye-head vestibular motion therapy, which is, you know, that's kind of a nutshell. You go, gosh, that's everything.
Yeah. Yeah.
So we did a lot of that. We used a lot of hypoglossal RPSS with her. So, you know, and that's something you'll see in a lot of functional neurology places. We use different electrical waveforms on different parts of the body. You know, some trigeminal nerve stimulation in a lot of these cases is really good. We'll kind of, or we'll come in under the tongue and shock the tongue for gaze stabilization or for other things too. But, you know, and her system just soaked that stuff up. So, you know, it's like, this is weird, you're going to zap my tongue, but I really, you know, she feel like she could see better right away. And we kind of found that she had a pathological ocular tilt reaction as well. And that's one of those things I found with the Maddox rod that Professor Carrick showed at physical exam, and he showed it over and over, and it's just a phenomenal application that we can do at the bedside. You know, so she's got a head tilt one direction, and again, the eyes kind of represent things like they don't perceive the head tilt. So we got her head and her eyes to reconcile, and you know, the sky's been the limit for her ever since. You know, she still has some occasional dizzinesses when she flies or when she goes to altitude to travel, but the positive about that is she travels.
Yeah.
She wasn't traveling.
Yeah.
She wasn't riding as a passenger in a car.
She couldn't even do that. Yeah.
She couldn't do that. Yeah. So, you know, and that's when, you know, yeah, let's get rid of the headaches and let's get rid of my fatigue. Well, you know, she's fatigued because her brain doesn't know where her head is in space.
There's something you had mentioned a little earlier about when, you know, we have concussions, our brains tend to make these compensations. Like this patient, you know, she was making compensations. So the kind of the automatic functions of her brain weren't working as appropriately as they should. So other areas have to kind of take over, right? So how do you try to approach that? You know, you want to build these areas up, but you don't want to decompensate them where they feel completely terrible, right? So
right.
So
and sometimes you do. You know, sometimes you do. You know, I've got this pathological ocular tilt reaction where she doesn't know where her head is, and you know, man, I got to get rid of that. You know, and sometimes you know, you get rid of that and you don't upregulate those other systems, and you go, well, shoot, you know, and like Professor Carrick will say, how could I have done that case better? How could I have done that case better? And you know, I've tried to do the same thing. But yeah, you know, we use a variety of things to kind of get the head and the eyes to match. Repositioning maneuvers are a biggie that we'll tend to use. Sometimes we'll do different things. Like with her and with a lot of my concussion and traumatic brain injury patients, I'll kind of tie different modalities together if they can metabolically handle it. You know, we'll use like a pulse oximeter. I use an HRV protocol a lot of times to kind of look at what the sympathetic versus parasympathetic system is doing, the autonomics. Because with a lot of these TBIs, you'll tend to see the autonomic system also is not functioning correctly. So, you know, in this instance, we kind of made sure that we didn't blow her down. Although I wasn't as worried about her autonomics because she was physically able to, you know, do a lot of stuff. You know, again, she works out 5 days a week, this, that. I watched it. Of course, I paid attention to it, but hers were pretty stable. So I could kind of give her the kit and caboodle. We used repositioning maneuvers with her. We integrated some RPSS during the repositioning maneuvers. So we're kind of trying to get the eyes to stabilize the whole time we're moving her through these. You know, sometimes she goes, oh, I have to do an Epley maneuver, you know, because it makes her a little unsettled. Yeah. And that's exactly kind of the thing you're talking about is we get rid of her compensation, but then we've got to come in and do some other things. It's like, yeah, we're going to do the Epley maneuver and you're going to feel crappy for about 5 minutes, you know, and then we do some eye head movement strategies with her to upregulate the RVOR, the angular VOR, so we can get her head and her eyes to match when she moves around. And then, you know, it's just for her, then it's like, I'm getting hugs and,
Yeah.
presents and these kind of things. And she's a trainer, and she loves our approach so much that, we just moved offices, and we've expanded our facility quite a bit. So we've got a whole dedicated rehabilitation area. You see me kind of looking off that way. It's in the back of the clinic now. And she's got stuff over here, and she's going to kind of work with us with people, because she's just really become so, in love with this kind of work.
Awesome.
So, yeah, super.
Yeah, and it worked. Obviously, another lucky patient to have found you out in Nebraska.
Yeah. Middle of nowhere.
Yeah. Again, and then something you mentioned, you like to monitor Autonomics with the pulse ox and other findings as you're treating patients, correct? We've talked a bit about, or we've talked with other guests about how in-depth the exam process is, and then every visit they like to check things. But something else that I really love about this profession, and it sounds like that you do as well, is that you're not just checking things at the beginning of each visit. It sounds like you're checking things after maybe each therapy or during each therapy, and really trying to make sure you're not exceeding metabolic thresholds.
Absolutely. Yeah, sometimes it's during the therapy. It's always, you're always watching something during the therapy. If somebody's following a target, you want to make sure they can stay on the target. You want to make sure you don't get these big pupillary dilations, or mouth tremors, or jaw movements, or these kind of things. And there's all sorts of stuff like that. And again, Professor Carrick is the best in the world at seeing that stuff. He sees it from across the room on us when we're doing these things at rounds, and you just go, how the heck did you know that? And you found those gray hairs in my beard too, dude. Don't tell people, It's just amazing. And again, the more and more exposure we get to him and the other faculty and professors, the more we seem to get that. And but it's a constant battle for sure. And sometimes you'll see people that come in with pretty stable autonomics to start with, and you get into your treatment and you start to change some things, and then you can kind of see those things get to be a little bit more sensitive, because they're functioning at a higher level than they were before you started with them. But, sometimes that system is used to, here I am kind of down in the dumps, and I've kind of learned to live with that.
Yeah.
But you go, well, now, hey, man, I've got access to these frontal lobe areas that I haven't used in a really long time. And then they kind of go in the tubes again. It's like, man, I didn't get headaches before I started with you. What's going on here? And you figure out, well, your saccadic function is 50% better. Your balance is 50% better. And most of the time when you get those things to happen, life does become easier for people. And some people, they'll tend to see these markers really, really get good, and they go, well, I don't know what the heck's wrong. Well, again, you've had an area of a brain, depending on how long the injury has been there. Sometimes if it's been there a while, man, I haven't really accessed my frontal lobe, my dorsolateral prefrontal cortex, whatever it is. And you start to wake those things back up a little bit, or start to give them access to those areas. And it is really, really sensitive. Yeah. So, you got to be cognizant of that stuff. Even, maybe you've been working with a patient for a year or two. It can happen.
Absolutely.
So you got to watch stuff all the time.
Mm-hmm. And I think by doing that, you're really creating a much more patient-centered and really specific treatment plan for that patient in front of you. Whereas versus like a cookie cutter approach where you just give them exercises and you're not monitoring these things, you don't know if it's helping or if it exceeds that point where now it's actually hurting. So it's a really good thing, I think, that we do this.
I think so too. I think with a lot of different trained practitioners than us, they tend to do those kind of things. Let's do, you've got a concussion. Let's do gait stabilization. Mm-hmm. And the context of those things matters so much. Are you lying down? Are you seated? Are you standing? Are you looking at a plaid background? Mm-hmm. Are you looking at a Buckeye logo in the background? Am I on a lawn? Am I, where am I? Textured background, all these things kind of matter. And I think that providers who don't get the training that we do, some of them get some phenomenal training. Don't get me wrong. I'm biased. No disclosures. I'm not faculty or anything, but I'm biased. I really do think we get the best training in the world for this stuff. But some other people are doing some really great work, but some aren't. And that's the thing. Is sometimes I talked with a doc, after the last TBI class I took with Professor Carrick, and we were talking about these patients who go other places and maybe have gotten some vestibular therapy. And my next case is actually along these lines. With dysautonomia being involved, they took her. She was in a car accident. And they took her and just had her stand on some foam and do a bunch of yes and no type things. And she gets in this car accident back in May, and she's had this daily headache since then. She works in a daycare, so you can imagine that's something. You probably don't want to have headaches when you're working with kids.
Yeah.
And before this accident, she worked in a daycare all day. She loved the kids, was able to go out and ride motorcycles and work out and all these things, very, very rich and full work life and, out of work life too. And that's what happens. She gets in this automobile accident again, just run into the store. I think we probably will see more of these types of things than any other concussions or traumatic brain injuries. Luckily, it gets diagnosed pretty early on that she had a brain injury. Which some people, they really don't.
Yeah.
It's like, well, your neck's, you got a little whiplash and this and that. And, they get the whiplash treatment and, the TBI stuff never goes away. She luckily got diagnosed with it right away, but gets thrown into the vestibular rehab paradigm, and again, with some people who do some pretty good therapy. But, this doc and I were talking about this, how some people don't do an evaluation before they throw people into these types of therapies.
Right.
And with this gal, they didn't put a pulse ox on her, didn't check her heart rate, didn't check her blood pressure, didn't check to see, can I stand flat, much less on a perturbed surface and tip my head back. And she couldn't do any of that stuff.
Yeah. So,
she gets referred to me from a speech language pathologist that I work with at one of the hospitals here in town, and usually this provider, she'll call me or she'll send me an email. Hey, got a tough one here. Can you see him? And it's like, heck yeah,
Yeah.
I'd love to, and I've rounded with them at Emmanuel Hospital in their physical rehab department, and they do a great job up there. And they've kind of rounded with me a little bit in my clinic, which it was at the old clinic where I was kind of stuck in a room with sticky notes on the wall and those kind of things. At the new clinic, it's like, come round with me. It's we could actually have an entrepreneur class here or something like that.
Awesome.
It's going to be really, really cool when we get it going. I got room for a gyrostim in the back someday. These kind of things. Let's get a rotational chair and really, really, try to figure out how to not screw it up too bad. So, she comes in and you really you start asking questions like, you've got some autonomic issues. Well, you're not menopausal yet. And with her, this was kind of a biggie. She didn't expect me to answer or to ask about her menstrual cycle.
Mm-hmm.
And again, luckily I've been trained super duper well, with Professor Carrick and with Dr. Clark. I've taken his metabolic series, some on demand I'm working through, and I've taken some of his hormone classes and things like that. And that's one of the things we talk about is you tend to see not only dysautonomia, but you see endocrine disruption in some of these cases.
Yeah.
And this gal has bled like every day since she's had this collision. And normally she was still pretty clockwork, and she was kind of like, what are you asking about that for? And I'm like, well, it's just one of those things we'll tend to see. Mm-hmm. She's had a few lab exams, but not to the depth that I was kind of hoping to see with her, especially as we got into this case. So, we send her back to her primary, who I've worked with on some other cases before. Luckily, my network reached out that far. And so it's like, hey, Dr. X, it's me again. Sorry, can you run these labs on me? And so we'll see. I'm still waiting on those. We had just kind of got into I kind of just dove into the pool with this gal. But we found again she was really unstable, and she struggled with these gait stabilization strategies at this other place that she was at. And it's kind of like, well, it's the right therapy. It's just the wrong time for you. Mm-hmm. And she's got this horribly decompensated autonomic system. You lay her down the heart rate goes up 20 beats a minute instead of down. You lay down, it should be easy, right?
Mm-hmm. Should be.
So
yeah.
she stands up, dizzy, almost going to pass out, headache. So, orthostatically speaking, it's not so good. Do some deep breathing strategies, some Valsalva things to kind of see what happens. None of it works really well is the point. So, we get in, and this is another one. This is a case where you go, the head and the eyes don't match up. We have this pathological ocular tilt reaction. Worked her through some posturography to kind of figure out which repositioning maneuver or maneuvers I used with her that I wanted to do. Again, did some RPSS because the eyes are just moving around when they're not supposed to. And with her, it was pretty not aggressive because her autonomics were so fried. Mm-hmm. And she sends me an email. Like I saw her in the middle of a week, and then I had her set up to come back in the next week. The way my schedule's set up, I can't do intensives with people right now. So I didn't get her back as quickly as I wanted, but I got back to her within a week. But she sends me an email like 3 days after, and I sent her just a couple easy things that she could do at home that wouldn't really exceed those autonomics. Mm-hmm. And she says, it's the weirdest thing, but I haven't bled since I saw you.
Yeah.
So what do you say? You go, well, let's hope it stays that way. That's the thing. I just go, well, hey, that might have been something we got right.
Yeah, it's incredible how far-reaching the brain is. Obviously, I mean, it controls everything, and you get things working okay, you get the autonomics working okay. Yeah, that's awesome. It's awesome you were able to help her out.
And the thing, a lot of times, again, I love the neurometabolic training I've gotten. Dr. Clark is stellar with that stuff. And he'll be the first one to say, well, don't just necessarily put them on supplements day one. Mm-hmm. Dr. Clark's really good about try your neuro stuff. And if it doesn't work, then, you start to think that. And I hadn't seen labs on her, so I didn't want to just throw a bunch of supplements at her. But,
right.
Some people sometimes, well, you've got this dysmenorrhea or this kind of a thing. Let's throw you on some adaptogens, or let's throw you on some progesterone, or, those kind of things. And, again, I hadn't seen any labs on her, so I didn't want to necessarily do that. But then it turns out it's like, well, shoot, right now we don't have to.
Yeah.
So you save her some bucks. She likes that.
It's always a good thing.
For sure. And I'm just thinking, gosh, if you've been bleeding every day, so we're going to see if she's anemic, because these headaches, they've progressively gotten worse. So I'm like, there probably is some of those concepts in there too. Yeah. And we're going to have to address them. But, got her in for the second visit, and, I thought, well, let's see if we can get at these headaches a little more. Tried some other different strategies with the headache. And, she emails me later that night, man, that's the first time my headache has gone away, even for a few hours, in months.
Yeah.
So again, it's like, she's wants to cry, I want to cry. And, it came back later because she had a really stressful situation come up outside of the workplace and home.
Yeah.
But again, she comes back the next day and she's like, hey, it's, instead of a 10, it's an 8. Mm-hmm. Okay. I mean, an 8 for this gal who, again, is one of those really, get up and go get them type people, an 8 she can work with.
Yeah. Yeah, absolutely.
And
anything in the right direction. And then just keep lowering it. Yeah.
And that's how that goes, and I didn't even have an insufflation bulb or any of these kind of things that I'd like to use with her. Mm-hmm. So it was just, again, basic eye head movement strategies applied as specifically to her presentation as I could be.
Yeah. Excellent.
And find things that she could do at home that I knew I took my best trained and educated guess with wouldn't be too much for her to handle.
Yeah.
And again, it's like, hey, if I'm not going to see you, just email me, call me. Hey, I'm getting XYZ now. What's going on here? Is this okay? Should I stop everything? Those kind of things. And I think that's one of the things that I try to do, and I think most of us do as well, is we keep in touch with people and can give them, some expectations about how they should respond to their therapies as we provide them as well.
Absolutely.
You're going to get people to surprise you, even though you are trained as well as you are in this, but you roll with the punches better, I think, because of the that we have.
Absolutely. Well, Dr. McClaren, we are just about out of time, but I want to thank you. I thought this was great. You showed how much you care for your patients, which I thought was phenomenal. B, the breadth and the depth that of the patients that you see, and the good work that you're doing for these patients in Omaha. But before we leave, I just wanted to give you the opportunity to let everyone listening know how they can get in touch with you and learn more about you, maybe your clinic, any other projects that you might be working on.
Awesome. We are located in suburban Omaha, Nebraska, La Vista, Nebraska. Our website is www.omahaspinecare.com because the guy that designed my website said that's going to be easier for people to spell than anything. So that's our website. My office number is 402-597-2869. And from there, you'll be able to get a hold of me on any of my forums that I have. I've got an office Facebook page that's Advanced Chiropractic and Neurology PC, which we respond to, as quickly as we can. We're same day response time, I'd say. So those things are really, really good ways to find me. I'm working with the Brain Injury Alliance of Nebraska on various projects, which is fun. They've connected me to some really cool cases and given me a chance to kind of reach and help some more people. I'm actually going to do a dysautonomia talk on one of their support groups next month. So that's really, otherwise, yeah, we're just, we're moved into this new space. We're developing it. We've got, we went from a 1,500 square foot facility to a 4,600 square foot facility. So we can do some on-site, sports specific applications and things like that for people. So that's where we're headed. Yeah, eventually we're going to add definitely some more applications. Like I said, rotational chairs on the wish list.
Yeah.
I'm really excited about the master's program that's coming up through the Carrick Institute.
Mm-hmm.
I'll take that, and I'm kind of hoping that might open up some university doors for our profession,
mm-hmm.
Which is always going to be good. That might help us reach even more people.
Yeah.
So,
which is always
other than just trying not to be too old and out of shape and keep up with my kids.
Awesome. Well, I won't take up any more of your Saturday, but I really appreciate you coming on and spending this hour with me. It's been awesome.
It was an absolute pleasure. Thank you for having me.
Oh, you're very welcome. Well, from the Neuro Wellness Podcast, this is your host, Dr. Coppus. Be well.